Hello. Excuse me. Hello. Welcome. You've made it to chapter 5. So now we're going to talk about predictive modeling in quality care. So along with going through the slides, I'll also read through some other notes that I have that'll be important for you to notate and document and keep record of. So we're going to talk about exactly what is predictive modeling. So predictive modeling is an analytical review of known data elements to establish a hypothesis that's related to the future health patients. Health plans and other health specialists generally use predictive modeling to anticipate future diagnosis for a patient. So in a nutshell, what predictive modeling is, this is a way of reviewing data to kind of predict the health status of patients. We're going to look at the data to see, are these patients over a matter of years, are they getting healthier or are they getting sicker? Basically, in a nutshell, what that phrase is. Helps prepare for future needs. Many third-party vendors have crafted formulas to assist with predictive modeling. And predictive modeling is also known health information from claims data like insurance claims, disease management, durable medical equipment request. And if you're not familiar, durable medical equipment, those are things like walkers, canes, oxygen tanks, things like that. Also prescription drug events and similar elements are used in predictive modeling. Chart reviews. So a chart review is basically reviewing medical charts. Now, chart reviews may display the incorrect ICD-10 code that's selected, or that a more specific code should have been reported instead. So basically, this is saying sometimes the wrong codes are reported, and the wrong codes can be reported because the physician may have selected the wrong code, the coder may have selected the wrong code, or also there could have just been a better or more specific code to use. For example, on a medical record, the doctor may say, the patient broke their left ankle. So just as a quick find, or just sometimes the physicians don't take time to go to the codes. Sometimes the coders don't take time to go to through the codes. So they might select unspecified ankle. However, they did specify in the medical record which ankle. So if the ankle is specified, there is a code for that. There's a code for your right ankle, there's a code for your left ankle, and then there's a code for unspecified. But if it is specified in the medical record, then we need to reflect that by specifying it with the appropriate code. These diagnoses can be corrected at the time of a medical record review. Human error, or EMR, and EMR is an electronic health records or electronic medical records, what we keep the medical records in electronically. You remember back in the day, we used to go to the doctor's office if you're a certain age, they used to actually pull the paper charts from the shelves. Now when we go to the doctor, they're typing in computers. That's an EMR. That's what an electronic medical record is. So human error or electronic medical record errors in code selection can lead to the application of wrong codes. You must also have the supporting documentation for all codes in the medical record, meaning that if you're going to use a code on the medical record, it has to be documented by the clinician in the record for you to use the code. You can't guess, you cannot assume, or any of those things. It has to be clearly documented for you to use specific codes. Predictive modeling is more of a financial tool as well. The more information that is known about the patient, the better the insurance carrier and other healthcare specialists can care for the patient based on the known diagnosis. For example, In the risk adjustment model, it's all about the health status of the patient. That's how much money the Medicare Advantage plans will receive from the payer for these patients. For example, if this patient has documented on record that they only have diabetes and chronic kidney disease. So if it's documented that they have those two conditions, then their Medicare Advantage company is going to get paid only for managing those conditions. So if this patient has a whole lot of conditions that the coder and the clinician is not capturing, that means that this patient is sicker and it's costing more money to care for this patient. But because it's not properly documenting, they're not receiving the appropriate money or the appropriate funding to care for the patient. It's all about money as well, as far as the health status of the patient. The sicker the patient is, the more money the plan will receive for their patient. EDD, that's early disease detection. That's detecting diseases early. Chart reviews also help you with EDD. So you kind of can read through the documentation, and also when you're selecting those codes that reflect whatever the clinician documented, you're getting a glimpse of what's going on with the patient. And then if it's clearly documented, sometimes you can catch things early. Predictive modeling HCC example. So you have diagnosis with no complications. So if on the medical record, a physician is saying, oh, this patient has diabetes with no complications, if they've selected that code. If you read the medical record, and the medical record saying that this patient is on insulin for this diabetes diagnosis, or they have a DME as a result of this, anything like that, then that means there are some complications. So again, if a clinician or a coder is selecting the diagnosis with no complications, however, when you read through the chart, there's DME, there's prescription medicine, there's procedures that's been done if you're looking through the data, there's labs, there's HCPCS codes, etc. That means there are complications with that specific disease. So known data is analyzed with additional variables, as we just mentioned, such as prescription drug use, DME use, and procedures coded. That's also used for predictive modeling. If we know that you have chronic respiratory failure and you're on oxygen, then 9 times out of 10, then you're going to continue to have chronic respiratory failure. It's going to be on oxygen, and it's probably not going to get better. So if you know that this patient in 2021 has respiratory failure, is on oxygen, then you can kind of predict in 2022, they're still going to be on oxygen with respiratory failure. So that's how they're using predictive modeling to kind of see what's going to be the next step for the patient's health status. Lab results also may be used. Predictive modeling must be paired with a professional coding chart review to validate these suspected conditions. So not only do they use predictive modeling to see what's going on with this patient, as you see, they also use us, professional coders, to take a look or review the chart to validate these conditions, to make sure that the documentation is there. So CMS has a STARS rating program. So as our healthcare industry has grown toward value-based care, and as you know, we're getting away from fee-for-service. Fee-for-service care means every time you go to the doctor, there is a fee for your service. So with the risk adjustment model, there's a payment per patient per month that these insurance companies receive for caring for these patients. So it's not on a every time we care for you, there is money involved. No, you just get one lump sum a month to take care of all of this patient's needs. So that's making the providers accountable for the patient's care. If you know that you're receiving only one lump sum a month to take care of this patient, you know that whatever this patient needs in regards to care has to come out of this money that they're giving you. And if the patient's care costs more than this that they're giving you, then it's coming out of your company's money and you're losing that way. So CMS has a STARS rating program. And the STARS rating program simply says, if you meet certain measures, then we'll give you a bonus at the end of the year, or we'll give you a bonus for meeting these measures. So that incentivizes physicians or clinicians to give quality care to these patients because they're measured on the quality of the care, not the quantity, not how many people they see, but the quality of the people that they do see. And if the quality of these people's health or these patients' health is being maintained properly and they're meeting these metrics in a good way, then these Medicare Advantage companies will receive a bonus payment. So CMS program geared toward improving the quality of patient care by holding Medicare Advantage programs to certain measurements to ensure standards are met to improve customer choices. Medicare Part C and D participate in the STAR rating program. This program incentivizes plans to continually to improve performance measures. The Affordable Care Act requires that CMS or Medicare make quality bonus payments to Medicare Advantage health plans based on the plan's quality rating. The STARS rating helps identify top performing plans. So if these people are trying to pick a Medicare Advantage plan, they can see which plan has the top ratings and choose from there. Medicare Advantage plans that earn 4 or more stars in a 5-star quality rating system will receive a bonus payment. Fewer stars than 4, there's no bonus. So here's the STARS rating measurements. Healthcare effectiveness data and information set. HEDIS. HEDIS measures. Those are the measures that they have to meet in regards to the star quality. And there are different types of measures, and we'll talk about them. HEDIS is a widely used set of performance measures in a managed care industry developed and maintained by the NCQA. Now, HEDIS was designed to allow consumers to compare health plan performance. HEDIS specifications include measures such as effectiveness of care, experience of the care you're getting, the description of the health plan, the information, access and the availability of the care that you're to receive, utilization of risk adjustment utilization, measures collected using electronic clinical data systems. Now, measurements are added, deleted, and revised annually. As we all know, things in healthcare change every day, so this is no different. Just like the book that you're studying from for this exam, that book has a new edition, comes out every October the 1st. There are codes that are deleted, there are codes that are added, and there are codes that are revised. HEDIS data collected through, collected through surveys, medical chart reviews, and insurance claims from hospitalizations, medical office visits, and procedures that you have performed throughout the year. Now, surveys cannot be done by that specific Medicare health plan. They have to be done by an outside or external organization, and that's conducted by the NCQA. So extreme and uncontrollable circumstances. Now, keep in mind these quality measures has to be met in order to receive the quality bonus. However, during one time, there was a string of hurricanes and string of other tornadoes, natural disasters, and things like that. So when we have natural disasters that occur, sometimes that can stop these facilities from meeting those measures because of the circumstances that were going on. So now there's a policy in effect if those circumstances are to occur. And it's called the extreme and uncontrollable circumstance policy. And as I notated, or as I said, CMS implemented this policy after a string of natural disasters. The quality payment program, when you're talking about the quality payment program, you have to know about MACRA, MIPS, APM, MIPS eligible clinicians, submitter types, submission types, quality, promoting interoperability, improvement activities, cost, and RAD-V. So the quality payment program. Let's talk about the quality payment program. In April of 2015, the Medicare Access and CHIP Reauthorization Act, which is MACRA, one of those definitions you just saw, was passed by Congress. Now, this act provided pertinent changes to the healthcare delivery system, how healthcare is delivered. MACRA laid the foundation for a new quality incentive payment program, another way to get paid. And it was called the Quality Payment Program, the QPP. The QPP launched in 2017, and it provides two directions in which eligible clinicians can participate. They can participate and get paid on a merit-based incentive payment system, which is MIPS, or an advanced alternative payment model, which is an APM. Those are the two programs they can participate in regards to receiving a quality payment bonus. Quality care. The goal of the quality performance category, now there is a category called quality performance. And the goal of that category is to assess the value of care to ensure patients get the right care at the right time. MIPS. MIPS eligible clinicians, groups, or virtual groups must submit at least 6 quality measures for the 12-month performance period. Now, each year, the risk adjustment score starts over. They're going to measure your score from January through December. And then when January comes in, then you'll get an annual, that patient will get another annual, an initial or annual visit to assess all of their diagnoses that are there for this upcoming year. Now, of course, there are some chronic conditions that you have that do not go away. So, of course, they'll always have those things, and it'll carry on to the next year. But you have to capture these conditions each year. So MIPS eligible clinicians, groups, or virtual groups must submit at least 6 quality measures for the 12-month period. Each measure is worth a maximum of 10 points. So if they got to submit 6 measures and each one of them is 6 points, 6 times 10 is 60. And that's the maximum of points, amount of points they can achieve. So MIPS. MIPS is the merit-based incentive payment system. So let's talk about MIPS. MIPS is a combination of 3 former quality initiative programs. Used to be 3 different programs, and they combined it to one, and they called it MIPS. The 3 different programs used to be the Physician Quality Reporting System, Medicare EHR, which is Electronic Health Records Incentive Program, or the meaningful use or value-based payment modifier, VM, and one new component. But they combined it to MIPS. MIPS eligible clinicians are excluded from reporting requirements and payment adjustments if they are in their first year of Medicare. There are qualifying APM. You remember we talked about just APM as well. They are qualifying APM participants if they do not meet or exceed the low volume threshold. Low volume means that you're not seeing a lot of patients. Your volume is low. So the goal of the MIPS, or the merit-based incentive payment system, is to provide a single quality reporting system with a single payment adjustment factor based on individual or group performance in Medicare Part B. So again, on the right side, as you see, you have access to the PowerPoint. There's things about the MIPS eligible clinicians. MIPS eligible clinicians groups Medicare Part B payment adjustments are based on performance thresholds and measures and activities. So they have to perform great in certain measures and activities category to receive these bonus payments. Promoting interoperability. There is a category called promoting interoperability. This performance category is to promote the security exchange of health information and the use of certified electronic health record technology for coordination of care. Basically, I'm saying, you know how now when we go to the physician's office, they'll give us an access code. We can access things through the portal, our medical records, schedule online, all of these things that we were not able to do a while ago. So this is promoting interoperability, promoting the coordination of care through electronics. This is this category that they're measured on as well. The scores for each individual measures are added together to calculate a score up to 100 possible points in this category. Now, the 4 objectives and measures are prescribing, you know how you prescribe through the electronic health records. You know, back in the day, we used to have to take the prescription to Walgreens or CVS or wherever we're going, Rite Aid. Now, we just go to the pharmacy, they've already called it in and we pick it up. Health information exchange, like your patient portal. Provider to patient exchange, and public health and clinical data exchange, your patient portals. Now, all measures in this aforementioned category, you can view it at this website here through CMS. Clinicians are also required to report measures from each of the 4 objectives for 90 continuous days unless an exclusion is claimed from this category. Now, before we talk about improvement activities, there is a quality performance category as well. And that category is to assess the value of care to ensure patients get the right care at the right time. Write that down, quality performance category. And that's just to ensure that the patients get the right care at the right time. So improvement activities category. So the improvement activities category, this category is to promote population management, care coordination, patient safety, patient engagement, practice access, emergency response, health equity, make sure everything is equal, mental health, and practice assessment. Now, there are 90 measured activities that are implemented to metrics that are met in this category. And all activities in this category are listed at this website listed below. There's also a cost category. This category was created for Medicare spending practices. CMS analyzes data from parts A and B, their claims, their insurance claims data, to calculate the total cost of a patient's care. The data is assessed during the year and during an inpatient hospital stay, during episodes of care. All those things, they go off your hospital records, your outpatient records, if you have surgery. You know, all those things are factored in when they're assessing your risk score. So your MIPS final score, merit-based incentive payment system, in which again, this is a system that incentivizes for meeting required measures to ensure the highest quality for patients. Each category carries a certain amount of weight in the final score, and the higher the MIPS score, the higher the payment adjustment. I just want to make sure you understood MIPS and exactly what it was. So APM, remember we mentioned that earlier, remember there were two options that MIPS eligible clinicians can participate in. So the advanced payment model along with the merit base are the two ways that they can go when it comes to qualifying for the quality bonus. Advanced payment models just is a group of clinicians, a group of clinicians who have voluntarily come together in an organized way to deliver coordinated care to Medicare patients. Let's say there's a cardiologist in the group, a urologist in the group, a reproductive specialist in the group. All of those clinicians come together in an organized way to coordinate the care that's needed for this patient. So here we are, we've wrapped up chapter 5, which is predictive modeling.